Dear students, I'll be discussing about the zygomatic complex fractures. I think last couple of classes it is you have been discussed on the mid-phase fractures that's involving your left foot 1, 2, 3, and it's continuation of that. You have your zygomatic complex fractures, which I'll be discussing about the classification, the clinical features, the investigations, and the management part of it. I'll be discussing under these headings. You have your introduction, your surgical anatomy, your classifications, which I've discussed before. As you all know that the zygoma is a very prominent bone on the face. Usually that is the very commonest bone affected in trauma, be it your road traffic accidents or be it your assaults. Usually since that's a very prominent bone, the first impact is on the zygomatic bone, and that gets the fracture takes place with the associated with the other bones, and so that's why we have to at least analyze what are different why it is involved and what are the different types of forces that are being taken place, and we try to plan our treatment accordingly. And I told you, since it's a very common and very keystone position of the adjacent to the maxilla, and if there's any impact onto the face, usually the zygomatic bone is the first one that gets involved and be associated with all other fractures, all other bones, that is your frontal bone, your globe, and that's why it's very important in at least to restore the facial contour, and in helping out the restoring the facial contour, because the zygomatic bone is very prominent, and unless that is restored, the facial contour is not will not be acceptable. And history is, you all know that there have been a lot of attempts been taken place to treat fractures of zygoma way back in 1650 by Smith Papyrus, and there are different approaches been tried out to reduce and to bring back the zygomatic bone to normal contour, and there are different approaches by transantral, by Lothrop, intraoral by Keene, and the most commonly used is the Gillies temporal approach, and you have by Sir Harold Gillies in 1927, and different fixation methods, be it wires or plates, is been tried out in fixing the zygomatic. And you all know that the functions of zygomatic bone is to protect the globe, because that's one which is the floor of the orbit, and that protects the globe of the eye, and based upon the clinical features, based upon the impact, even that gets involved, which I'll be discussing in detail in the features. So that's, in general, it protects the globe of the eye, and almost all the masticative forces that has been at least your occlusal forces or masticative forces that has been transmitted will be transmitted via the zygomatic bone to the cranium, and usually any impact on the zygomatic bone, before it gets transmitted, it gets absorbed by the zygomatic bone. That's why the force that is distributed to the cranium is minimized. So in some way it protects the impact onto the cranium, because this is the one which takes up the maximum load, and it absorbs the pressure, that is all the forces, and that thereby preventing the impact to the cranial bone before it reaches the brain. Anatomy, you all know that it's in Greek word, it's called yoke, and which is, I told you, is very prominent bone on the face, upper and lateral part of the face, and it forms the principal means for transmission of your occlusal forces from maxilla to the base of the skull. There are different, there are major role, which I told you, which are different four processes of the zygomatic bone. You have the orbital, the frontal, the temporal, and maxillary process. You have four articulations, again with the frontal bone, your temporal bone, maxillary bone, and your sphenoid. And you have muscle attachment, you have masseter and temporal fascia. The masseter attached to the lower border of the zygomatic arch, and the fascia to the upper border of the zygomatic arch. There are different classifications that have been put forward by different authors in trying to at least to for planning your treatment, because based upon the type of features we try to plan accordingly. So here, according to Manson, by CT analysis, he has found out that there is a lot of, based upon the amount of energy dissipated by the facial bones, he has classified as high energy fractures, moderate energy fractures, and low energy fractures. And based upon displacement, we plan a treatment. Okay, this is all there in your textbook. You just have to go back and refer that books and try to get back into the classification. Commonly used classifications are Owen Williams and Knight and North classifications. Again, this is fracture stability after elevation, fracture stability and stable after elevation. You have arch fractures, rotation around there's rotation of vertical axis, rotation around horizontal, which I'll be discussing shortly, because based upon the rotation of this vertical axis, which we call it as medial rotation or lateral rotation or inward rotation or outward rotation. And finally, you have your comminuted fractures where the whole of the zygomatic bone gets crushed out into pieces. Knight and North, based on anatomy, you have no group, 6 groups where there is no significant displacement, and group 2 is direct blow that buckle the malar eminence inwards. Group is unrotated body. You have medially rotated, lateral rotated. It's all there in textbook. You just have to go back, and at least for the convenience part of it, at least a couple of classifications that's well and good for your exam point of view, because if the question is asked on the zygomatic bone malar complex fractures, we can always try to explain in detail, writing about this couple of classifications, the features and the management part of it. So according to Zing, you have type B, A, B, C. I think that's what I told you. We can always write a couple of at least 2 or 3 maximum sufficient for the exam point of view also. If you want, you can always go back and read the other classifications, because that's for the benefit of the postgraduates. We try to explain all this. And I told you again, based upon the horizontal and the vertical axis. The vertical axis is imaginary line drawn from the frontozygomatic suture down towards the first molar teeth, and the horizontal axis is from the horizontal plane from the zygomatic arch going towards the nasal bone. So if there is an impact along the vertical axis, there is an inward displacement or medially rotated, and if it is based upon the impact on the horizontal axis, it is inward or outward displacement. So just based upon the axis, we try to discuss or try to classify whether it is medially rotated or laterally rotated, or it is inwardly displaced or outwardly displaced. If it is vertical, it is usually inward or outward, or medially. If it is horizontal, it is medially and laterally displaced. Anyway, you just have to mention that in your exam point of view. And again, I told you, it's a special classification. We have your different 7 classifications, whether it is medially rotated or lateral rotated or infield displaced and comminuted fractures. Features. This is what is very important for you. So the moment you see the patient, we can easily identify whether the patient has got zygomatic complex fractures. So the moment you see the patient, we can know that there is an impact taking place on the zygomatic bone, and one of the common features is your periorbital ecchymosis and edema. Usually there is an impact, you have patient with a ballooning phase, or I told you edema of the face, and you have your seepage of blood in the subcutaneous tissue below the eyeball. The patient will end up with periorbital ecchymosis. So you have a blackening of the blackened discoloration below the eyeball, below the eye, and that will lead to a periorbital ecchymosis and edema. Flattening of malar prominence. As I told you, the patient has got a flattening of the malar bone because there is an impact on the zygomatic bone. Usually that's depressed. So there will be a flattening of the face. So to identify the flattening of the malar prominence, you always go back behind the patient. So look it from above, from the head point of view, and we can easily see, which I'll show you the representation, which we can easily identify whether the zygomatic bone is displaced inward or laterally. Just by placing a finger on the zygomatic bone, we can easily identify whether the zygomatic bone is inward, or if it is medially rotated or medially displaced or laterally displaced, just by placing your fingers on the zygomatic bone, and is always coming or looking out from behind the patient from the head point of view, which I'll show you in the zygomatic representation. Flattening of the zygomatic arch is saying it as flattening. You can always say it's a depression of the zygomatic arch, because if there is a depression on the left zygomatic arch, you obviously know that the zygomatic arch is involved and it is fractured. It fractures like a tripod fracture, wherein you'll have a depression on the lateral side of the face, So we can easily identify the patient if we can patient turns, or if you can turn the patient on the left side or right side, based upon the type of based upon the side of involvement of the fracture. We can easily see the depression on the lateral side of the face. So then obviously we can know that there is a zygomatic arch fracture, right? And which I'll tell you all then discussing about the various the treatment mode of zygomatic arch fractures. And pain is, as I told you, any fracture that matter, patient will end up with the severe pain that gets depressed after some time. Ecchymosis of maxillary buccal sulcus. As you all know that there is a seepage of blood, there is a fracture into the submucosal region. And so the moment you try to lift your buccal sulcus, you can only see there's an ecchymosis there. That's one of the commonest features associated with your maxillary and zygomatic bone fractures. And deformity of the zygomatic buttress of maxilla. As you all know that there is a fracture, the impact on the zygomatic bone, obviously there will be a depression that causes deformity, and which we can always try to palpate by intraoral palpation. We can see there's a deformity taken place, and that we can identify by just palpating on the buccal sulcus region, and which we can plan our treatment based upon the displacement. And deformity of the orbital margin. As you all know that is the one which the infraorbital margin is the one which protects the globe of the eye, and the moment there is an impact of zygomatic bone, there will be a step deformity we can see in the infraorbital margin. So always try to palpate the intraorbital, the supraorbital margin. We can easily identify there is a step deformity at the intraorbital margin and at the lateral orbital margin, because you have a frontozygomatic suture there. Usually that gets displaced in your zygomatic bone fractures. And that based upon the type of deformity, we plan our treatment accordingly. Trismus, which is very commonest finding associated with zygomatic arch fractures. Because why there is a trismus? Because there is an impact on the zygomatic arch which causes depression of the zygomatic arch. So just below your zygomatic arch lies your mandible, that is your coronoid process of the mandible. So the moment if there is a zygomatic arch fracture, there is an impingement of the coronoid by onto the zygomatic bone, and usually the zygomatic bone, once it gets depressed, it impinges on the coronoid process, thereby restricting the movement of the coronoid. So they ask the patient to open the mouth, he cannot open the mouth because there is a bone there restricting your movement of the coronoid, and that patient will end up with trismus. So this is very common finding, very typical feature if there is a associated zygomatic arch fracture, and that can lead to patient will end up with trismus. So the moment we identify the patient with trismus, we have to go for a treatment, because usually I told you if there is a displaced or there's a displaced fracture, we plan our treatment, and if it is undisplaced, we can try to observe it and try to plan it accordingly. So abnormal nerve sensibility. You should all know that there is a infraorbital nerve associated with your zygomatic complex fractures, and there is an impact on the zygomatic bone. The nerve gets slightly pressurized or damaged, and that can land up with paresthesia of the infraorbital region. So in such case, the infraorbital nerve is to be relieved, and the moment there is a pressure that is relieved, the patient will have some sort of paresthesia for some time. Usually it is transient unless the nerve is cut. So we have to be careful not to damage the infraorbital nerve. Epistaxis. As you all know, there is a bleeding from the nose. Why? Because there is a fracture of zygomatic bone, and just behind the zygomatic bone lies your maxillary sinus. So usually the maxillary sinus gets filled up with blood, and the blood has to come out through something, and come out through the middle meatus to the nose. So patient will have bleeding from the nose, and that's called as epistaxis. So that's again one of the commonest features associated with your zygomatic bone fractures. The patient will have a bleeding from the nose, which is called as epistaxis, and that gets depressed at least reduced after some time. Not of a big concern, but we can easily identify a patient with zygomatic bone fractures because it's a bleeding from the nose. You have subconjunctival ecchymosis. It is, I told you, it is a very typical feature associated with your zygomatic complex fracture. patient will land up with subconjunctival hemorrhage because there is a hemorrhage taking place associated with frontozygomatic or infraorbital margin fractures, and there's a seepage of blood directly into the eyeball, and then you have your conjunctiva there, where bulbar conjunctiva, where it looks very bright red in color. We can easily identify that there is a seepage of blood into the conjunctiva, and the brightness is because there's a direct diffusion of oxygen into the conjunctiva. So the whole blood appears very bright in color. And the typical feature again is we cannot delineate the lateral border of it because that's a globe, right? So moment we cannot appreciate the lateral aspect of that complete the lateral part of the redness. We can if we ask the patient to move the eyeball towards medial side, even moodily, we will not be able to appreciate the end part of it, of the redness, because it's a globe and always the whole of the conjunctiva is involved. So that's one of the typical features of your subconjunctival ecchymosis, and it is usually typically a bright red in color. Crepitation from air emphysema, again I told you, is there is always crepitation taking place because as a emphysema is nothing but air that is being released, and usually a moment you try to breathe in, breathe out, and usually goes through the sinus, right? It gets humidified there. So sometimes the moment it's fractured there will be a seepage of blood into the subcutaneous tissue. So patient will land up with crepitations of the subcutaneous tissue on the face. The patient will have got it's called as emphysema, and usually that gets resolved after some time. But again, it's one of the commonest findings associated with your zygomatic fracture. Displacement of palpable fissures. You have your palpable fissures, you have your lateral canthal attachment, your middle canthal attachment, and the patient will have sort of anti-mongoloid slant based upon the displacement of the globe, because you have displacement of palpable fissure taking place. And you have your unequally pupillar levels, as I have told you. Once moment there is a displacement of the zygomatic bone, even the globe of the eye that can displace, there will be some sort of derange, that is comparing with the opposite side, we can see unequal pupillary levels. Diplopia, as I told you, is what is called as a double vision, and usually there are two types of diplopia, monocular and binocular. And usually we are worried about monocular, because moment if there is a monocular diplopia, that means there is a globe of the eye that is a traumatic injury to the globe, and usually it is the muzzle or lens gets detached. So in such cases we have to be very careful and refer to the ophthalmologist. Binocular, usually it's because some sort of a muscle entrapped in the zygomatic bone, and that can be relieved by reflecting the zygomatic bone, and the patient will have a normal vision. So if there is a diplopia, if it is double vision, and if it is monocular, we are worried. So refer him to the ophthalmologist. If it is binocular diplopia, but it's double vision on seeing both the eyes, then that means there is some restricted movement of the globe, because there is a muscle that gets entrapped, or there is a fat atrophy or herniation of orbital content. In such cases, we can try to relieve that by lifting the globe of the eye, freeing all the muscle attachments. If there's any attachment, usually you have your inferior rectus and inferior oblique that gets entrapped with the fracture segment, and that can be relieved from the zygomatic bone, that is from the floor of the orbit, and that can relieve the diplopia. Okay, and in ophthalmos, as I told you, the whole globe gets sunken behind, and there's a measuring method called Hertel's exophthalmometer to measure the ophthalmos. If so, you can always try to identify if there is a sunken globe, and usually because you have your orbital content or orbital fat which is lying below the globe of the eye, and that gets herniated into the maxillary sinus, your muscles can get herniated into the maxillary sinus, causing the sunken globe, that's called as ophthalmos. So that can be relieved by again reconstructing this floor of the orbit, because sometimes the floor of the orbit gets typically damaged, and in such cases we have to protect the globe of the eye by lifting the globe of the eye by putting a graft there and try to reduce the enorthomas. Proptosis, again, because if there is a seepage of blood behind the globe, it's called as retrobulbar hemorrhage, which will cause pressure input on the globe of the eye, and the patient will land up with proptosis. So immediately we have to relieve the pressure from the globe of the eye by doing a lateral canthotomy or lateral canthotomy, which I'll be discussing in the treatment part of it. So we can try to relieve the pressure, relieve the blood seepage, blood collected from behind the globe. So patient will have a proptosis. Right. So I think I'll just go back, and so these are the typical clinical features associated with your typical the zygomatic fractures, and you have to be worried about the diplopia, your trismus, enorthomas, right? And usually I told you the globe of the eye is protected by your, what is that called? It's called the suspensory ligament of Lockwood, which is attached to your tubercle, that is Whitnall tubercle on the lateral side, and to your medial lateral anterolateral crest on the medial side. So usually that is the one which protects the globe of the eye. So if there is a fracture of the frontozygomatic region of the zygomatic complex fractures, and if there is a fracture below the Whitnall's tubercle, you don't have to worry much. But if there is a fracture above the Whitnall tubercle, that is on the frontozygomatic suture level, and if that gets displaced, the globe also eye can also get displaced. And that's why people will end up with all different types of ophthalmic complications, like a double vision or the unequal pupillary level. It's because there is a high level fracture, and that causes the displacement of the zygomatic bone, and along with it you have the Lockwood ligament which gets displaced, and you can see a different obviously some ophthalmic problems. So these are all the findings which we have to clinically identify the type of fractures. Usually zygomatic bone, the moment you see the patient, we have to identify all these features, and there's almost 17 features which you should know, and try to plan your treatment accordingly. And I'll be discussing about so this is what I've been telling you about the testing for zygomatic fractures of zygomatic bone. We can obviously see that, the moment you try to go behind the patient and try to put your finger on the zygomatic bone, if there is a depression of zygomatic bone, we can easily identify the level of the depression. Can you see on the diagram on the right side, where you're placing your index finger onto on the bone, we can see there is a flattening of the zygomatic bone. So these are different methods of testing by palpating method to identify the zygomatic bone as such. So if there is a depression, then obviously we know that there is a fracture of the zygomatic bone. And the other two fingers, placing on the fingers. Anyway, this is the simplest method. Always try to go behind the patient, put your finger there on zygomatic bone. There is a depression, we can easily identify there is a fracture of the zygomatic bone. In such cases, we have to plan, because the treatment is based upon the type of clinical features you have. And as I told you, if the patient has got trismus, we have to plan your treatment. If the patient has got diplopia, we have to plan your treatment. If the patient has got flattening, we plan the treatment. So based upon the type of features, we try to plan the treatment accordingly, which I'll be discussing to you. I told you this is what happens if there is a trismus, right? So say there's a zygomatic arch fracture which is impinging on the movement of the coronoid. So if there is a restricted mouth opening, the patient has got trismus, that means there's a depressed fracture of the zygomatic arch which causes restricted movement of coronoid. In such cases, we have to plan your surgical treatment and lift the depressed zygomatic arch fracture so that the coronoid process movement is not restricted, and that can prevent the trismus. So typically, if the patient lands up with trismus, this is a very common finding associated with zygomatic arch depression, which will cause trismus to the patient, which you have to surgically plan your treatment. Unequal pupillary level, as I told you, there is a globe of the eye which is suspended by your Lockwood ligament, and if, as I told you, there is a depression, that is, if there is a frontozygomatic separation and the whole thing gets separated out, we can see that the pupillary levels get disarranged, unequal pupillary levels. So that means that we have to plan your surgical method of treatment of trying to get back the zygomatic bone into its normal alignment and try to plan your surgical treatment. And this is what I've been telling about the abdominal nerve sensibilities. You have your infraorbital nerve there, and this infraorbital nerve usually gets best because it's associated with zygomatic maxillary suture. If there's a pressure onto that, the patient usually end up with paresthesia of the infraorbital region, but that doesn't matter. You can always try to plan your treatment and try to relieve the pressure around the infraorbital nerve. And there will be some sort of transient paresthesia for some time, but usually that can get relieved after a couple of weeks. We can try to use some medications for that and try to reduce that is region, because usually the intraorbital nerve gets regenerated fast. The patient will have normal sensation after some time. So this is again, these are the, as I told you, you have your periorbital ecchymosis. By typically looking at the patient's face, we can identify, can you see the bright red in color of the globe of the eye? Because there is a subconjunctival ecchymosis and periorbital ecchymosis. So we can always see that if there is a fracture of the zygomatic bone or zygomatic complex fractures, patient will have a subconjunctival ecchymosis, periorbital ecchymosis. So one of the typical features, just by looking at the face, we can know that there is a zygomatic complex fractures. And that when you see patient has got a sunken eye or a depressed globe, we can always identify such features in these patients. I think I'll be stopping with this. And regarding the SAOC, so we can always try to, regarding the investigations and the treatment part of it, I'll be discussing about in the next class. So, we can easily identify, as I told you, this zygomatic complex fractures is very commonest fractures taking place on the facial skeleton, and just by looking at these clinical features, we can easily appreciate the problem there. And if there is, I told you, based upon the type of features, we plan our treatment accordingly, because unless it is undisplaced fracture, we try to avoid the treatment. If it is a displaced fracture based upon the fecal features, if there is a trismus or a diplomia, we plan our treatment accordingly, right? So, so these are all. And before planning your treatment, we have to have our investigations ready, just by looking, and which I'll be discussing in the next class about the different types of radiological investigations and your methods of treating the zygomatic bone fractures. Okay, so I think we'll discuss in the next class.